Okay, great. So I'm going to talk a little fast. If I'm talking too fast, I am from New York. Just slow me down a little bit, but in an effort to save some time. What I'd like to do is just present an overview for you of where the research is and why nutritional status should really be incorporated into your daily practice. So we often get this question, I think, both in high-income and low-income countries. High-income countries wonder what the prognostic importance of nutritional status is. In low-income countries, it's similar, but also how do they fit it in with already a high clinical volume relative to staffing. And there was a study conducted in 2005, which really launched a lot of the research that I'm going to talk about today. And this was a study that was performed in about 800 children with AML. And it was the first study that demonstrated a difference in survival in patients that were either underweight or overweight. And what you see here by this figure here is that here are patients and their survival that are in a middle weight, what's called, but what means like a normal healthy weight. And then when you look at overweight and underweight patients, you see a significant difference in terms of survival. And these risk ratios were quite high. So for patients that were underweight, there was an 85% increased risk of mortality. And patients that were overweight, there was an 88% increased risk of mortality. And this really kind of launched a series of research. And I think one of the quotes from the conclusion of this study really kind of drives me every day, and I'll quote Dr. Bev Lang, who led this article, in that the effect of BMI on outcome in pediatric AML is not trivial. The reduced survival in underweight and overweight patients is roughly equal to the improved survival accomplished by 10 years of progress in pediatric AML. So really by addressing nutritional status, we can really augment all of the wonderful scientific advances that are occurring for the general treatment of pediatric oncology. And this has been demonstrated, the importance of nutrition in terms of survival and in terms of daily clinical care has been recognized just by looking for nutrition articles in PubMed. You see a profound increase in articles from the 70s up to recently. Nutrition has been incorporated into the vision and the initiative from Children's Oncology Group. In fact, they will be performing their first NIH-supported research study in children undergoing stem cell transplant, the Nutrition Committee. And then, as Dr. Arora mentioned, in 2013, SIOP recognized that nutrition was important, particularly in developing countries, and that we need to have a standalone committee to really help improve the education and clinical research. So just to start out with a few definitions, again, I think historically, and certainly when I started working in pediatric oncology, we really only thought about undernutrition and weight loss. But now we know that malnutrition is not just undernutrition, that there's overnutrition as well and obesity. And this is really starting to impact not just high-income countries, but low to middle-income countries are having the increased burden of addressing undernutrition right alongside with overnutrition. And so the clinical importance, again, to characterize the pattern of growth in children. The goal is to, while you're delivering the necessary cancer therapy, to also promote growth and development, just as you would in a healthy child. I'll talk a little bit about body composition and kind of what that entails and why that's important to consider in your practice. And then also, again, particularly in regions where there's micronutrient deficits, to look at prospective dietary data to identify potential risk. And again, as I mentioned, there's a lot of research that's associating nutritional status with both outcome, quality of life, and treatment-related toxicities. So nutrition's difficult to investigate, I think, and so a lot of the research has been slightly heterogeneous in terms of its outcome. And part of that is because we have so many factors that are affecting daily nutritional status. So we have just endemic nutrition factors, energy balance, kind of what the effect of cancer itself, the therapy has on energy balance. You have the cancer itself causing aberrations in terms of the metabolic function of the cells. You have medications that are impacting dietary intake that may, increase or decrease appetite. And then for low and middle income countries, you have these added pressures of access to all the needed supportive care medications, particularly those that affect appetite and intake, such as antiemetics and mucositis management. You have patients wanting to choose or complement with complementary therapies. And then just staff knowledge and training. It can be a challenge, as well as families' access to food once they're out of the hospital and in their home setting. In terms of the incidence of undernutrition at diagnosis, it really varies by region of the globe. And this figure is categorized by Central and South America. These are Europe and the US, and this is Africa. So we're seeing about 40% of children in low and middle income countries are presenting with at least undernutrition at diagnosis. Again, some of that is the disease itself, presenting with more advanced stage disease than you would in high income countries, and some may be just endemic to the regions in terms of access to food. But already up front, we know that 30 to 40% of children are already going to be undernourished. But as I mentioned, undernutrition is not the only challenge facing clinicians these days. Overnutrition and obesity has really emerged as a global health problem. Unfortunately, the United States has really led this global crisis, and really it's penetrating all aspects of the globe, including Africa and many parts of Asia. So in terms of the percentage of patients that are overweight or obese at diagnosis, a lot of this data is from high-income countries, primarily Europe and the United States. And what we're finding is about 30% of patients are overweight or obese at diagnosis. And this varies even regionally within the United States. So when you get to the southern part of the United States, we're actually seeing up to 50% of our patients are starting therapy kind of with with one little challenge on top of the cancer itself. So the Children's Oncology Group, the Nutrition Committee, initiated a meta-analysis to look at the prognostic value of using BMI at diagnosis and looking at its association with outcome. And what we wanted to do was kind of compile all of the research studies that have been done, which have primarily been in AML and ALL, and look to see, well, what is the value? How strong are these associations when you pull all these? About 8,000 patients were included in this meta-analysis. And so what we found was that indeed there is a persistent and clear effect of overweight and obesity on overall survival and event-free survival. You can see that there's about a 30 to 35% increased risk of mortality among patients who are overweight or obese at diagnosis. And what was even more compelling is that when we looked at older patients, so adolescents, and then younger children who are classified as high risk, that risk increases to 54%. So they had a 54% increased risk of mortality, and this was very strongly significant with a very narrow confidence interval. When we looked at AML, again, these are circled in red for you. We're seeing very similar trends, 36 and 56% increased risk, and we weren't able to do it in older patients, but we're seeing a consistent pattern in terms of weight gain, in terms of the risk of effective obesity and overweight at diagnosis on survival. And so what's happening not only at diagnosis but during therapy? So I think we've all read in the literature that children with ALL have weight gain, experience their own weight gain during therapy. And this figure is again from a COG trial, and this is from CCG 1961. Which is a high-risk protocol. And what's interesting, and what I would just want to really bring your attention to, is this increase in weight is really happening initially in therapy. But what's happening is that they gain weight basically during that induction time frame, and then it fluctuates during therapy, but it persists to the end of treatment. And this has been, again, replicated in several trials. But what's concerning about that initial weight gain is these are odds ratio in terms of the amount of weight that patients will gain and what their risk of maintaining that, what their risk of being obese by the end of diagnosis is. And you're seeing, again, 7 times increased risk of being obese by the end of therapy, 3 times depending on how big the BMI score, and this is for males up here and females here. Again, the more weight they gain in induction, they have 14 times increased odds of being obese but, by the end of treatment. And what's a challenge for us, and I think why nutrition is important, is that those patients that are gaining weight during therapy, most of them are not overweight or obese at diagnosis. In fact, what some of the studies have shown is that those patients who are overweight or obese at diagnosis are actually either staying that way or losing weight. And it's the healthy weight kids that are going in the wrong direction. So really kind of pointing to interventions happening kind of early on in therapy to prevent that weight gain. Now, there appears to be, in terms of weight gain, there appears to be a pronounced difference that's highly significant between whether regimens that have more prednisone versus dexamethasone. This is comparing standard risk CCG protocols on therapies that had more prednisone versus more dexamethasone. The blue being dexamethasone and the red being therapies that entailed more prednisone, and what you're seeing if dexamethasone is part of the treatment, that there's an even higher risk of weight gain, and some newer data that's coming out actually on children treated on the Dana-Farber protocol are actually, that uses more dexamethasone compared to COG protocols, is actually finding the same thing, that dexamethasone is really even a bigger offender than prednisone in terms of facilitating weight gain by the end of treatment. And, you know, what's optimistic, though, is that if we intervene during therapy, we actually can remove this risk. So this study looked at the percentage of patients, the percentage of time, I should say, that patients remained in an unhealthy weight category. And so I'll bring your attention to figure B here. Patients that were underweight, this is a little hard for you to see, but it is the blue dotted line and the red dotted line. So it's this line here and this line here. Those patients were either overweight or obese at some point during therapy, but actually through interventions came into a healthy weight category. And actually what you see is that by intervening during therapy, it removed the adverse effect on mortality when compared to those patients that actually stayed in that at-risk weight category throughout the course of treatment. And that has been replicated in low and middle income countries, particularly in the study in Guatemala that actually intervened early on, remediated undernutrition, and actually found that survival was the same. However, it appears that the way that children gain weight during therapy is not equal, and that really whether they're gaining fat mass or fat-free mass is a very strong predictor of the severity of mortality and potential and treatment-related toxicity. So what you're finding here is these are cases and these are controls, so these are children with ALL. And this, this sharp line here is lean mass, and this is fat mass, and two measures of fat mass. And really what I want to show you here is that over the course of therapy, so here's baseline and then at 12 months, you have this very sharp rise in fat mass compared to healthy children who are naturally going to gain weight over the course of therapy, but by we're naturally going to gain weight just due to child growth and development, but nowhere like a child undergoing treatment for acute lymphoblastic leukemia. And what's important to look at that is because as the literature is evolving in terms of looking at body composition and its association with outcome, that by simply measuring height and weight and measuring BMI percentile, that it's not a real good indication of what's happening kind of inside the body in terms of how the weight is being developed. So this was a study that looked at the concordance between BMI percentile and body fat percent. And what you're seeing is these, these open lines, these open circles rather, are really demonstrating that there's a very strong discordance between BMI and body fat percentage. And when you look at BMI Z-score and you're looking at its kind of trajectory over the course period and comparing that to body fat percent, you see these, very two different trajectories going on, when you're looking at BMI versus actually looking at body composition. So there's several hypotheses as to why this is important. First of all, why in ALL they're gaining weight, but also what's happening and why is this affecting outcome. And so I think it appears that it's different. Certainly I'm focusing on AML and ALL because that's where the majority of the data is at this time. But AML, it may be more toxicity related versus ALLs. There appears to be an impact on actually the disease response. And there's a lot of preclinical work looking at obese mice with leukemia and looking at what's called like the microenvironment of the cells and really how they respond to treatment based on the amount of fat they have in there. And there's, again, a number of explanations as to why this is going on. Again, I mentioned the difference in steroids, so certainly the type of protocol, and the type of steroid. Pharmacodynamics is somewhat controversial still, whether or not there's a different distribution between obese patients and normal weight patients. Again, more needs to be done in that arena, but originally when this data was coming out, there was a real heterogeneity in terms of dosing of chemotherapy in obese and overweight patients, but that seems to be somewhat standardized, but although not completely at this point. And then there's other causes, potentially of increased BMI. There could be genetic factors, certainly polymorphisms in the leptin gene, although the observational studies have not had great associations between that being a real causative factor. Then you just have very practical things that occur during therapy: reduced physical activity, excess dietary intake due to the steroids, and learned food behaviors because of that, as well as psychological conditions that may evolve, depression, anxiety, et cetera, that can all increase or decrease food intake over the course of therapy. So kind of now that we've kind of talked about anthropometric data, what about dietary intake and what patients are actually eating during the course of therapy? And, is there a role for us to actually modify dietary intake to not only manage the weight gain, but also change the composition? And as I showed you those stark increases in body fat percentage, can you change the diet or evaluate different kinds of diets that can at least lessen that increase in body fat? And diet, we know for several decades, it's been associated with the development of cancer itself. Again, that's really in adults, not necessarily in children. We know that in children, again, a lot of this is from high-income countries, that in general, survivors of childhood cancer do not meet dietary guidelines. We know that diet quality after cancer treatment in adults impacts mortality. So the better quality diet, the lower mortality adults have due to secondary cancers, et cetera. And this study found, was fairly a large study, found a 33% lower all-cause mortality in patients. This quartile here represents patients that were very adherent to kind of healthy dietary guidelines. In Europe, there is the famous EPIC study that's in nearly 400,000 males and females. Again, very similar responses. the more adherent patients are to kind of a good quality diet, the less risk of cancer and also late effects related to cancer. So going back to our pediatric population, how does the therapy itself affect nutrient intake? Again, there is a lot of the data, again, is limited to very small samples, but generally speaking, we know that children with cancer tend to eat differently during controls, and this was a small study in about 100 kids with ALL, just comparing, mean intakes over the at a cross-sectional time in therapy, and you're seeing significant values between the two groups. But what's interesting about pediatric ALL particularly is that not every child responds differently, responds the same. So, we would intuitively say that, oh, they have all these steroids, they're eating more, that's why they're getting heavy. Well, actually, this study shows quite the opposite, that yes, indeed, some patients are increasing their intake, but actually, a lot of patients are staying the same and decreasing intake, but still gaining weight. So again, suggesting there may be other causes in this. Again, talking about whether or not we can manipulate diet to, again, mitigate that development of obesity. There have been some studies, not in oncology, but in healthy children, showing that if they adhere to a better quality diet, that they don't develop sarcopenic. So that's kind of the term used for that increase in fat, specifically weight gain versus just overall body weight gain. And we also know that diet quality during therapy can impact treatment-related toxicity. So we know that certain micronutrients can impact treatment-related toxicities, more days in the hospital, at different variations in therapy. So based upon that, I'm going to briefly go over a study that actually looked at dietary intake in acute lymphoblastic leukemia. I think to date, this is probably the largest prospective dietary cohort in children with both ALL and children with both standard risk and high risk ALL. And what we did during this time is look at dietary intake, actually prospectively during therapy, and also collected nutritional anthropometric data. So here's diagnosis, and then at the end of induction, and then all the way at the end of about 3 months into the maintenance phase of therapy. And what we wanted to do is kind of see how dietary intake fluctuates during the course of therapy. This is just the demographic variables. Again, I'll skip through this just in order to save time. In terms of patients, what they were eating, again, now I'm just reporting right now at diagnosis how they were eating. At diagnosis, we're finding that a good portion of our patients are exceeding the dietary guidelines. And what's interesting about this study is it includes the United States, Canada, and Puerto Rico. And although Puerto Rico is part of the United States, their actually survival in pediatric ALL is around 70%. So it's similar to that of low and middle income countries. Again, kind of they're still teasing out exactly why that is occurring, but how patients are eating, what nutrients they're either exceeding or below, also is varying, particularly between actually all three countries. And, we found significant differences between standard risk and high risk. Again, starting this, we thought that high-risk kids would for sure be eating less and come in more depleted potentially, at least from a dietary standpoint. Actually, we didn't find that at all. We found them quite similar, actually, between the two groups. But, kind of the nutrients that are coming to light are zinc, vitamin D, folate, kind of the common offenders where we have a group of patients that are exceeding or below the DRIs. In terms of how kids are eating when comparative to normative values, so kind of what healthy kids in the United States and Canada are eating, you'll see that here, this is our group of ALL kids, and these are the recommended guidelines, and kind of this just pictorially shows you that generally speaking for all age groups, these kids are way above the recommendations. Again, a little surprising, given that this is at diagnosis, so despite ALL being kind of a quickly onset, relatively speaking, disease, these kids, it's not impacting their dietary intake right before therapy. They're still way above the recommended intakes. What we're also finding in this group is that, this is looking at them through the course of therapy, is that there's a very sharp increase again in BMI. And this is kind of the first study to actually report on BMI in the Dana-Farber, according to the Dana-Farber protocol. And while it's very similar to COG protocols, it does use more dexamethasone, and we're seeing very sharp increases. So follow-up is kind of right around the end of treatment, within probably 6 months of the end of treatment. We're seeing in standard risk, kids jumping 20 percentiles. In high-risk kids jumping 14 percentiles. Again, this is much higher than the reported literature. Let me skip here. I kind of talked about that. All right, so just in terms of final remarks, take-home messages for everybody. I hope I kind of convinced you that nutrition status and nutrition is a modifiable risk factor. So we know that both under and overweight impact survival. It's less clear about toxicity, but we know we're more clear on survival, and that by remediating it, we mitigate that risk. Some work suggests that diet quality may be a partner. We can partner with diet quality in terms of helping with nutrition-related toxicities and outcome, and especially what I'm referring to here is that sharp increase in fat-free mass, that if we have patients eat a better quality diet, that we may lessen the gain of fat-free mass. Again, sequential observations are essential. I was actually at a conference a few weeks ago in Turkey, and there was probably, I don't know, about 60 physicians in the audience, and I asked them, who here, performs sequential nutritional assessments on their patients. I mean, and I'm just talking about height and weight, and 5 people raised their hand. So we really need, part of that's education, part of that's understanding that if you pay attention to it, you maybe, you can impact further increased survival among your patients, but really doing it once at diagnosis and kind of carrying on through therapy is not the best. We need, there's a lot of variations in clinical practice, and this is even within institutions, but I think this really just drives home the point why we have this workshop and, education. And again, I think partnering is key to this, and that's particularly international partnering, so we could advance the science in this work. So, thank you. And here's my email, and the SIOP PODC Nutrition Group, please join. So I believe that Dr. Rogers is next.